So, as the team said, I'm Dr. Jenkins. I am one of the OBGYNs here at Monadnock, for those of you who may not be familiar with me. Thank you for joining me on this lovely Wednesday evening to talk about breast health. A little bit about myself. This is a topic that is near and dear to my heart. My mother is a breast cancer survivor. I have 10 years as of February. And so some of my goals for this evening's talk, I want you to understand your risk factors for breast cancer, what you can do to detect it early, what you can do to lower your risk, and just feel empowered to take control of your own breast health. So, quick question and answer. Does anybody know what the most common type of cancer is in women? I'll give you a hint, you're here. It's breast cancer. And the average woman in her lifetime, does anybody know about how likely she is to develop breast cancer? No. So it's 1 in 8 women at average risk are going to develop breast cancer in their lifetimes. And so there are some risk factors that can be changed and some that can't. So let's first look at the ones we can't change, and then we'll get onto the ones that we can do something about. The biggest risk factor is just being born female. Men do get breast cancer, so obviously if they notice any concerning symptoms, lumps, bumps, they need to report that to their doctor as well. But it is mostly a disease of women. Family history is another strong one, especially if you have a close family member. That's going to be somebody like a sister, a mother, or a daughter. That can definitely raise your risk of breast cancer. And some people are actually going to qualify for genetic testing to see if they carry a gene that puts them at higher risk. I'm going to go over those people later in our talk. But that might be something that you could discuss with your provider if you fall into one of those categories. Age, as we get older, becomes more common. Most breast cancers are found in women over 55, but we are starting to see them in younger and younger patients. Just having dense breast tissue. So when you get a mammogram, it reports out the density of your breast tissue, and you're either going to have dense breast tissue or not dense breast tissue. Women that have dense breasts have a higher chance of developing breast cancer, and those cancers are harder to find on mammography, unfortunately. However, at the time, there aren't any current guidelines on changing your screening based off of your breast tissue density. That is something that there is research being done on, so that might change in the future. Also, just the longer you're having your menses for. If you start them younger or you go through menopause later, that breast tissue is hormonally responsive and it's getting exposed to those hormones for longer. So basically, if you start your period before 12 or you go through menopause after 55, those are both risk factors. Race and ethnicity. So white women actually have a higher chance of developing breast cancer, but unfortunately, Black women have a higher chance of dying from breast cancer, also have a higher chance of developing it under age 40, and are more likely to develop what's called triple negative breast cancer, which is a type of breast cancer that's a little higher risk. Fortunately, there are a lot of risk factors we can change. So one is alcohol use. Any amount of alcohol use raises the risk of breast cancer. The best option is not to drink at all, but if you choose to drink, it's recommended that women drink no more than 1 drink a day, and that's going to be 5 ounces of wine, 1.5 of hard liquor, or 12 ounces of beer. It's a little bit complicated on this one. Being overweight or obese does raise the risk of breast cancer, and that risk is higher in women who've gained weight as an adult after menopause. Before menopause, it's almost a little protective. Being physically inactive. So the American Cancer Society recommends at least 150 minutes of moderate intensity exercise. That's going to be something like taking a brisk walk, doing yard work, or 75 minutes of vigorous intensity exercise, going to the gym, running, really getting that heart rate up to decrease your risk of breast cancer. And this is obviously a very personal decision, but having children late in life or not at all also can raise your risk of breast cancer. The data here is really complex. But as a general rule of thumb, women that have their first child at age 30 or later have a slightly higher risk of breast cancer. But we also see higher risk of breast cancer in women who breastfeed. Immediately, it's a little bit of a higher risk, and then after lactation, it actually drops to well below that risk. So breastfeeding over the lifetime is a lower risk of developing breast cancer. This one's also a little complex, but hormone replacement therapy can raise your risk of breast cancer. The way hormone replacement therapy is done has been changed so much over the years that sometimes the studies that we use to say, hey, this may raise your risk of breast cancer may not actually apply to our current medications we use. But if you have a uterus and you get something called a progestin to keep you from developing uterine cancer as a result of hormone replacement therapy, that can raise your risk of developing breast cancer. We actually didn't see that in women that were only receiving estrogen, so women that have had a hysterectomy and don't receive estrogen. So One of the biggest things about, yes, ma'am?
Could you just repeat that last part again?
About hormone replacement therapy and breast cancer. So whether or not how we do hormone replacement therapy actually changes depending on whether or not you still have your uterus. So women that do not have a uterus, that have had a hysterectomy, they only get estrogen as part of their hormone replacement therapy. And those women we actually didn't see a higher risk in the studies. Women that got an estrogen plus a progesterone or progestin, we do see that higher risk. But that was also an older study that used medications we don't typically use as much. So it's a little hard to say now if that effect still applies. Because we have that study, it's still pretty much part of the standard counseling whenever we talk about hormone replacement therapy with patients. Any other, yes, ma'am?
And the length of hormone replacement therapy?
Again, controversial. Usually the recommendation is to use it for the shortest amount, the lowest dose possible and the shortest amount of time possible. So as a general rule of thumb, we're gonna try to get patients off of it sooner rather than later. Any other questions? And please do feel free, if you have a question during the talk, feel free to raise your hand. I'm happy to answer questions at any time. We are a smaller group, so hopefully this can be a little bit more of a conversation. So what can we do for screening? Because early detection saves lives, right? The most important thing is your mammograms. It is the most effective form of screening for breast cancer. We see in women that get breast cancer somewhere between get their mammograms yearly, somewhere between a 28 to a 40% risk reduction in their risk of dying of breast cancer. So in all women who just get that recommendation alone, we already see a 28% decrease. And in women who actually get screened yearly, it's up to a 40% decrease in the risk of dying of breast cancer. For average risk women, yes.
What is the current recommendation for a younger woman being screened with a mammogram?
Oh, we're getting to that. No, it's okay. So for average risk women, that is women without a strong family history of breast cancer, the recommendations are to start at 40. It used to be a little controversial, and there were some societies that were recommending starting at 50, but as I said earlier, we're starting to see breast cancer in younger and younger women, so every society now just agrees across the board, for your average risk patient, start at 40. If, though, you have a first-degree relative with a history of breast cancer, again, a sibling, a parent, a child, then you start screening 10 years when you are 10 years younger than they were when they were diagnosed. So if your mother was diagnosed at age 45, you get to start at 35, not at 40. And there is some variation in how often that should be done. And that's going to be every year to every other year, depending on who you ask. So the American College of Radiology, National Comprehensive Cancer Networks, those recommend annual screening. American College of OBGYNs, which I am partial to, being an OBGYN myself, recommends annually or every other year. The American Academy of Family Physicians and the U.S. Preventative Service Task Force both recommend every other year. The American Cancer Society recommends annually until you're 54 and then annually or every other year. Personally, if you come and see me in the clinic, I will always recommend annual screening for my patients. Yes. And that is because screening every other year, the goal of mammograms, the goal of screening is to find cancers when they're so small that you would never pick them up on exam before you have symptoms. And so they can be treated as early as possible. And screening every other year can miss up to 2/3 of cancers that would be found if you screened every year. And so 2/3 of those cancers may actually become clinically relevant. You've got a lump, you've got skin changes, you've got something that flags that is you going, oh, there's something wrong here. And so screening every other year actually has a higher chance of dying in the next 10 years of breast cancer than screening yearly. So if you come and see me in my clinic, I will always tell you, just go get your mammogram every year. But if you're low risk and you really do say, hey, I don't want to, it's not completely unreasonable to do it every other year. So some common questions I get in my clinic whenever I talk about mammograms. I have patients that tell me, oh, I'm not convinced that's going to be safe for me. Isn't there radiation with a mammogram? And the answer is, yeah, there is. I won't lie to you and say there's no radiation. A mammogram is basically where they take your breast, compress it between two plates, and take an x-ray of that breast to look at it. And so it's about 6 weeks worth of the radiation you get just living your life. So the benefits, though, far outweigh the risks. In a group, if you take 100,000 women and they get mammograms every year, over the course of 10 years, you're going to see about 125, maybe, extra cases of breast cancer resulting from that radiation out of 100,000 women, and 16 of them may actually die of that cancer. But in that same time frame, we've prevented 968 deaths from breast cancer. Meaning you are 60 times more likely to have your life saved by annual mammography than you are to unfortunately die of a breast cancer resulting from that same amount of radiation. This might be a little bit of an unpopular answer whenever I answer it. Does anybody know how often most professional societies recommend routine annual self-examinations or routine breast self-examinations? Christy's back there smiling. She knows the answer.
Am I wrong to say that they've gone away from that?
You are not.
Right?
So ACOG and the American Cancer Society actually do not recommend routine self-examinations anymore. The U.S. Preventative Services Task Force also said don't do them in their 2009 guidelines, and that's never changed since. They just have a really high false positive rate. So you are very likely to find something on exam, go in, get imaging, potentially even get a biopsy, and they were never really shown to improve outcomes from breast cancer. That being said, we do still recommend something called breast self-awareness. And that doesn't mean that you shouldn't know what is and isn't normal for your own body. You're in the shower, you notice a change, you notice you're looking in the mirror, you notice something looks different. By all means, you need to let us know if you see any of these concerning changes. Lumps. So you may, especially if you're younger, you're still having your menstrual cycle, notice some changes in your breast throughout that month and throughout that cycle. And that's normal. Breast tissue is really hormonally responsive. As your reproductive hormones are fluctuating, the tissue is going to respond, the tissue is going to change. What we worry about are lumps that don't change over time. They don't go away. And so if you have a concern though, at any point, please let your provider know. We're always happy to see you and do an examination, see if maybe you need an ultrasound, you need a mammogram, you need anything else to work that up. Skin changes, so a new redness of the skin in an area that's not going away, or what we call peau d'orange skin, which is just fancy French for orange peel skin. So the skin can become dimpled almost, and it looks like the peel of an orange. If you see that, that can be a sign that there's a breast cancer underlying that skin. That's what's called inflammatory breast cancer, and that's rare, but it can be very serious and actually grow very quickly. So that is a skin change never to ignore. If you see that skin on your breast looking like an orange all of a sudden, come in, get it checked out immediately. Nipple discharge, especially if it's only on one side or it's bloody, can also be a sign of breast cancer. So any new nipple discharge should always be examined by your physician. A lot of those patients are going to end up having mammograms, imaging to make sure there's not something going on in the ducts of the breast. Or a new nipple inversion. Now I say new because we see nipple inversions pretty frequently, and if your nipple has always been flipped in instead of out, that's normal. That's just your body. But if all of a sudden it changes and it flips in, that can be a sign there's a mass deep in the breast that's starting to pull on those ligaments and pull your nipple in. So again, a change in how your nipple looks, always report that. Now, clinical exams are a little bit different than self-breast exams. As physicians, as providers, we do a lot of breast exams. We kind of know what we're looking for here. There is no society that says every woman should get one of these, but there are generally a recommendation to offer them. And so it's every 1 to 3 years from 25 up. Once you hit 40, most professional societies are going to recommend that you have one annually, or at least that you be offered one annually. Genetic screening is going to depend on your family history. So this is one of the big things for early detection is, do you need to be screened more frequently? Do you need to be screened with an MRI or an ultrasound in addition to just your mammogram? So different reasons that you could have that would be if you have a first-degree relative who's a man who has breast cancer. That is an immediate, you should be screened. If you have a first-degree relative with breast cancer and she has at least 2 other relatives that have breast cancer. If you are of Ashkenazi Jewish descent and you have breast cancer. If anybody in your family has ovarian cancer, those are going to be the same genes, and so that screening is also recommended. But yeah, the big thing, if you take nothing else away from this talk, please get your mammograms every year. Any questions? Like I said, they are like, can you do breast talk? I said, yeah, it's going to be mostly me harping about getting your mammograms. Yeah. That is the biggest thing. PA,
Like,
yes.
The first couple of times I've had mammograms,
Mhm.
I had recognized dense tissue.
Yes.
And this last time,
So that changes as we age.
does it? Okay.
It does. Younger women tend to have denser breast tissue. As we age, that dense tissue tends to get replaced with more fatty tissue that's easier for the x-rays to see through. And therefore, you are more likely to have things recognized.
Well, I'm not young.
Okay.
I have dense breast tissue.
Yep, that's not a guarantee that it's going to change.
And I, as I've learned more, it's like, it doesn't sound like it's very reliable to get that mammogram, which you kind of alluded to. So it's like, what's the best way to keep track of things?
The best way is still the mammograms. We are currently there are some research being done on should women with dense breast tissue be offered screening with ultrasounds, with MRIs. And certainly, if you're a high-risk patient with dense breast tissue, it's very worth having a conversation with your provider about whether or not to consider, should I be getting MRI? Should I be doing something else to screen? But for average risk women, right now the recommendation is still just annual mammograms. That may change.
How many different kinds of mammograms are there?
So there's the 2D and the 3D tomosynthesis mammograms.
Okay.
Yep. So they're pretty equivalent. You can get either done. 3D, we do think may be a little bit better with that dense breast tissue. Yes.
How come there's not more push or information out there about the change in having a mammogram every year? Because a lot of the information still says every other year, especially if you're over 75.
Right. And sometimes they used to even say over 75, oh, just don't bother. And then we started noticing even in older women, we see a pretty significant decrease in the risk of dying from breast cancer.
Because I'm 81.
Right.
Because my mother had ovarian cancer. I went for a mammogram every year and it was fine.
Mm-hmm.
And I was diagnosed with triple negative breast cancer this year.
Mm-hmm.
And fortunately, it was small, early detection, all those things that we want. But you still go through chemo,
Right.
and which is hard on the body. And it really angers me that there's not more push and more information out there. And what can we do so that we can get that out there?
Right. And like I said earlier, there are some professional societies that are still recommending screening every other year, which I personally do not agree with.
No.
The American College of Radiology, if you look at their position paper on it, they say women should be empowered to make that choice. If you choose for yourself, after knowing that you are less likely to die of breast cancer screened annually, if you still choose to get it done every other year, fine, but that is your choice. It should not be made for you. And I wholeheartedly agree with that I think the lowest risk is just to be annually screened.
Yeah, a lot of women don't want to have it because
Right.
it's uncomfortable.
It's
but not
uncomfortable.
horrible. Everybody's different, and
Oh, I'm saying certainly not like chemo or radiation.
Right, exactly. It's far more comfortable than that. Mm-hmm.
yeah.
Mm-hmm. And that compression is actually very important during your mammogram as well. And so I think that's something a lot of people say, well, is there a way to do this and not have to get squished? Because the squishing is uncomfortable. And that compression actually helps us, one, use a lower x-ray dose. Two, if the breast is not fully compressed, you can actually get little overlapping bits of tissue that look like abnormalities, so you're more likely to get called back in when you didn't need to be called in. So it's annoying. The compression helps a lot. It's nobody's favorite, but it really is important.
It's actually better than the MRI.
That's true.
So have it. And,
I just brought my mom in today at 82
Mhm.
for exam, and we had to do extra because there was an overlap and
Mhm.
straighten that out so she wouldn't have to come back and have
Right.
an ultrasound, and went through exactly through that today.
But avoiding that overlap actually is really helpful for the radiologist to be able to get the best view possible of your breast so that we're not missing things.
And as far as the every other year, I mean, one of my best friends had a gap, not even a whole year gap.
Mhm.
Like she was behind, I don't know, 6 to 9 months at the most for her annual. Had a very fast growing tumor, like serious, had surgery, chemo, she's had immunotherapy, I mean, you name it. It has been a really long haul, and that came on, and it was like a 6 centimeter tumor that
Oh,
grew
wow.
over no time, you know, and that to me is just right there. I mean, I know it's not exactly common to have that situation, but, I mean, yeah.
Yeah, the goal of screening is to find things early, so, yeah.
Is the screening equipment here the 3D?
I believe so.
Yes.
Yes, it is. One of our nurses is back there going, yes.
It used to be the 2D, now it's the 3D.
Yeah, it's the
and
3D.
a lot of patients actually had to have a new baseline
Mhm.
after doing both, but it's the 3D, yeah.
So I thought you said on one of the screenings to have, that you don't need mammograms after age 70.
No, so there are some professional societies that say that.
Like family practice.
Family practice does. American College of OBGYNs recommends it be shared decision making between you and your provider. American College of Radiology says no, there's no maximum age because we still see benefits in your health from screening throughout the lifespan. When it's recommended to stop is basically if you, one, have gotten to the point in your life where you say, you know, if I found something, I wouldn't do anything about it. I would not want to have surgery. I would not want to undergo chemotherapy. I would not want to undergo radiation. Then it might be reasonable to stop. Or if your health has become so poor in other ways that you likely are going to die of something else before you would die of your breast cancer, then stop screening. But otherwise, no, continue looking. It could save your life.
I mean, I will say, it is physically, that's something to consider as well.
Right.
I mean, my mom, for example, uses oxygen, a walker. I mean, it was a team effort today, to be honest.
Mm-hmm.
And she did a great job, but looking forward in the future, that may become physically, it's not an accessible screening, for,
Right.
let's say, in reality. Yeah.
But at least she had a choice,
Correct.
Absolutely.
which is,
It's totally up to her if she wants to do that again, and yeah.
because it's interesting. I mean, I'm pretty healthy, but I know I talked to friends that were my age and they said, well, I don't think I'd go through chemo. Well, when your choice is going through chemo and dealing with the side effects, which are not always pleasant, or dealing with the problems that occur from metastatic breast cancer,
Oh,
going
Mhm.
to whatever
absolutely.
organ
Mhm.
it chooses to go to,
Yeah,
that to me would be worse.
absolutely.
And, because I really questioned whether I wanted to do this.
Mhm.
No, just picking up on what she has said. My sister has metastatic breast cancer. My
Mhm.
mother died from ovarian cancer. I have been told by family practice, you don't need a mammogram anymore.
Oh, that's what, that really
And
angers
so,
me.
I know we don't have grand rounds here, but how do you convince?
And I think that does come into where their professional society still recommends, their professional society does still recommend considering stopping at 75. And to me, it's just if you're in good health, especially if you have a family history, I would keep screening. But that's what my professional society says, that you should have that choice. And so that's where it's a little tricky.
I'm just curious, because my mom died from ovarian cancer, and I was always really good about going in and getting
Mhm.
checked. No one ever said to me that because of that, you should go and have a mammogram and you should have it every year.
Mm-hmm.
No one ever said that to me. I just took it upon myself.
I'm glad you did.
So I'm wondering, did anyone ever tell your mom?
Well, I worked in healthcare, so
Yeah.
did tell my mom. My mom was never told that she had ovarian cancer. It was
Oh.
one of
Oh,
those.
that's a whole other,
Yes,
yeah.
that was in one of the best hospitals in New York City, and they weren't telling. They didn't want anybody to know.
Oh.
Yeah.
Well,
So-
I can't help but reflect a little bit on, now it's a much bigger conversation about research in women's healthcare.
Right.
I mean, there are major gaps. There are major gaps both for women, clearly for older women. You know, it's like, I mean, the study that you were referring to, I'm guessing, about hormone replacement therapy and the controversy around it is a very old and questioned.
It is an older
research.
study that uses medications we don't typically use to treat hormone replacement therapy.
Something when you said that, you know, not that there's not research that's up
Right.
to date using the medication or comparing the medications that are used today is mind-boggling, you know,
Right.
and really frustrating that there's a major gap. Yeah.
It's a bit off the topic, but we've been tying it in with ovarian cancer and breast cancer.
Mhm.
We were talking about genetic screening.
Yes.
Is there not a blood test that rules out that we should be given but not covered by insurance?
So, genetic screening can be a little tricky. There are pretty strict criteria for who might qualify for it. One of them would be if your mother had ovarian cancer, you could be offered screening automatically for it. It is a blood test. It can be run, it's pretty easy to run these days. You just come in, we draw a kit, we send it off to the lab, we have our answer in about a month. The risk of everybody getting screened for that is that we all have mutations in our genes. Most of them don't ever cause a problem. And so if everyone got screened for those cancer-causing mutations, you'd have a lot of what we call variants of uncertain significance, which basically means you've got a mutation and we don't know if it's ever going to cause trouble. Meanwhile, though, if you have that information, are we looking at things like, do you need a mastectomy? Do you need to have your ovaries out? Do you need to be put on lifelong medication? Whereas if you're higher risk and we see a mutation in that gene, we can say with more confidence, that likely is going to cause trouble. And here's the steps you can do to mitigate your risk of developing cancer. So it's not a one-size-fits-all, but there are criteria for deciding who might benefit from having that genetic testing done.
Does Medicare pay for, or supplemental insurance pay for that blood test?
I have not had problems getting it covered whenever I've ordered it. Now, I will never make a blanket statement on what insurance does and does not cover because that is my lovely office staff that deals with prior auths is sitting right here. They can tell you that is constantly changing. But
Wisdom.
I have not had trouble getting it covered. In people that meet what we call the National Cancer Comprehensive Network, I have not had issue getting those patients their genetic testing.
And is that criteria a mother who's had ovarian cancer?
Mm-hmm.
Thank you.
Are you going to go have a conversation with somebody potentially?
Well, I have somebody that had ovarian cancer.
Yeah, so you would.
And when I was younger and had a conversation with my doctor, and the doctor said, well, it was a one-off, so to speak.
Mhm.
And so chances are it really isn't necessary. But now I have a daughter and a granddaughter,
Mhm.
and so maybe now I need to do it.
So yeah, you would, from the sounds of it, now I don't have your whole chart in front of me, but from the sounds of it, you may actually benefit from getting that screening done. So that would definitely be something to talk to your provider about. Hey, do I qualify for this? Because if you have a mutation, then you could talk about getting your daughter screened and getting her daughter screened. And so it's a decision that could have multi-generational effects.
I thank you for teaching me that, and I thank you ladies for sharing these stories.
Yes, thank you
Because
so
it has
much.
invigorated me to pursue further. Thank you.
I had genetic testing done by Dana-Farber
Okay.
because of this. But I don't think it was a blood test.
There are some tests that do saliva or cheek swabs. It's a genetic test.
Yep, it was a cheek swab.
The one I run through my office it's a blood test.
I thought maybe it was.
No. Now, when did you have it done?
5 years ago.
Okay. So after 2016, there have been some changes on the genes that are being tested. So
What if you have a male in your family that had breast cancer?
So again, if it was a first-degree relative, you could consider. Uncle's a second-degree relative, so is he still with us?
No, and
Okay.
he did not die from that.
Okay. So ideally we want to test the person that actually had cancer. But you could, again, with a history of male breast cancer in the family is another red flag. Maybe consider getting that genetic testing done. Because, again, it's mostly a disease of women, so if the men manage to get it, something might be going on there.
Can you be denied insurance if you have to change?
Nope.
insurance?
So there's something called the Genetic Information Non-Discrimination Act, the GINA Act for short, but it prevents, basically it says you cannot be discriminated against based off of your genetic status. Now that is a federal law, those are always subject to change, but as of right now in the United States, no, it is illegal to discriminate against somebody based off of their genetic history.
Get it now.
Breast density, when does that change usually?
Just throughout the lifespan, there's not a defined age cutoff. Like I said, some younger women go and their first one is not dense. Some older women go and they are still being told they have dense breast tissue. And so it just, as you age, it does become more likely that your breast tissue will become not dense.
I had dense last year.
Mm-hmm.
This year it's not dense.
Okay,
Does that sound right?
that does.
Okay,
That
I
does.
saw that.
Is there anything with you that?
Really?
Yeah,
I was like,
No, it's a lot of it's just genetics and your own body makeup, as those glands over time do start to get replaced with fatty tissue, but it's not a hard and fast cutoff. Oh, by age 60, by age 70, that should happen. Some women, it never happens.
And not dense is better than dense.
Not dense is lower risk for breast cancer and also increases the likelihood they will find something on your mammogram. So, ideally,
Because they can see it.
they can see through it a lot better.
It doesn't mean it's more likely that it'll be there.
No, it does actually.
Oh, it does?
Mhm.
Okay.
It does too, because more of that tissue is that glandular tissue that tends to develop problems.
How effective is an ultrasound if you have dense breast in seeing things?
That's one of the things that they're currently researching. Right now, we don't have the data to say for sure that an ultrasound is as effective of a cancer screening strategy, where we know mammography saves lives. So like I said, if you take one thing away from my talk tonight, it's please go get your mammograms. But in the future, there may start to be more studies showing that women might benefit from having an ultrasound done.
Isn't that what they do though? If you have a questionable mammogram, you then go for an ultrasound?
So it can be part of it. So when you go and you get your annual mammogram, that's called your screening mammogram. You go, you get your 2 views, they look at it, they say this is fine, or they say we might need more pictures. And that's called a diagnostic mammogram when you get called back. And in that case, you get to hang out and stay until they're sure that your mammogram is fine. Sometimes that can also include an ultrasound at that point. But that's more, we have a targeted area we're looking at. Any other questions, comments?
It sounds like we've got to go forth and just tell everybody every year.
Yes, please, please.
That we know and love, we just tell, forget what you read.
And I feel like you may have all met Debbie coming in, but she is one of our occupational health nurses. She helps run our New Hampshire breast and cervical cancer screening program. So if you do not have insurance, if you financially, breast or cervical cancer screening is out of reach for you, if you live in the state of New Hampshire, the state will pay for screening and treatment if an abnormality is found. So don't let financial reasons be the reason you don't get screened. Any other questions?
Gratitude.
Okay, perfect. Well, thank you all for coming and, like I said, spending your Wednesday evening here with me. Please do feel free to reach out if you have any questions. I'm easy enough to find. I'm right here at the hospital. So, all right. Thank you all.